Welcome to Valley Fever Voices podcast, your go-to resource for current topics in valley fever, bringing critical awareness about valley fever to the medical community and the general public. Today, joining us is Dr. Fariba Donovan, Associate Professor of Medicine and Infectious Disease Physician and Research Scientist at the University of Arizona. Dr. Donovan has an extensive background in medical mycology with experience in both clinical practice and advanced biomedical research. Her work focuses on the early detection and improved diagnosis of coccidioidomycosis, aka valley fever, through groundbreaking research on fungal virulence factors and host pathogen interactions. Dr. Donovan aims to advance rapid, accurate, and cost-effective diagnostic tools. Her efforts not only enhance patient outcomes, but also promote better antimicrobial stewardship and public health strategies. And I'm honored to have her with us today to share her expertise and insights in the clinical and scientific aspects of valley fever. Thank you, Dr. Donovan. Thank you so much for joining me today.
Thank you for having me.
So I actually saw you at the 69th annual coccidioidomycosis case study meeting. And you were you moderated the symposium on the risks of valley fever with the immunomodulators. And that's a big thing. So maybe we can start by talking about that, because that's actually a big thing in human medicine and veterinary medicine with our biological response modifiers.
Well, thank you. That's a dear to my heart topic. So thank you for bringing that up. Yes, you're right. That is a very major topic that in human medicine, I don't see animals, but in my work every day, I see somebody on one of the new immunomodulators in the market. So if I take that back, I started working on this specific topic a few years ago. And the question was, we get a lot of these patients coming to our clinics. And most of the time, the physicians who do prescribe these medications are people who are treating the patients with autoimmune disease. So those are like rheumatoid arthritis, with the joint pain and discomfort, sometimes Crohn's disease, ulcerative colitis, sometimes the skin manifestation of autoimmune disease like psoriasis. So you see that the broad range of these diseases are out there, and different physicians who take care of these patients nowadays are being introduced to these new medications in the market. The best regimen, you see that all the time in the commercials on TV. Oh, if you take this medication, your psoriasis completely resolved. Or if you take this medication, now you can play golf because your joint pain is gone. And most of the time, these medications are somewhat affecting the immune system. Now, how and which medication is more problematic is what we are interested. Because, overall, what we talk about is the immune system is important to keep all infections under control. And one of those infections is our disease, valley fever, which is a fungal infection. So what happens is when these immune cells get suppressed by these medications, and rightly so, to suppress the disease manifestations such as rheumatoid arthritis, now the fungal infection that might be dormant in your body, such as valley fever, have the opportunity to show their bad head and potentially cause problems. So the question we always get from the physicians who send these patients to us and the patient is, okay, the medication I'm on, whatever it is this safe for me to take in an area which is endemic for valley fever? And to answer this question, what I always recommend to the physicians who send this patient to us, repeatedly monitor these patients, repeatedly do the blood test. And as you know, sometimes the blood test, our blood test is not always positive in case of positive disease. However, if you repeat it, you can increase the yield of
Mhm. Yep.
the test becomes positive while patient is on this medication. Then the question is, what do we do about that? Should we stop the medication? Well, any patient who's on this medication, they love it because that works. Now they are back to their functional life. That's the quality of life they have. The psoriatic plaques are gone, so they can go out, or they can walk, they can work, they can do exercises. Well, I don't think the best solution is don't take the medication, because now their quality of life is affected. However, if they take the medication, is there a specific risk for diseases such as valley fever? So you mentioned that we developed this expert team of experts on valley fever. And if you remember, one of our experts is actually Dr. Chen from Stanford, who gave a wonderful talk.
Yes. Yes, she was great.
Yeah, and she actually kind of summarized her talk of IDSA conference that last year in our conference. So I actually invited all these people to have a group of experts to see, okay, what's the consensus? And that will be the basis for our paper that is being developed right now or written, the manuscript that will be submitted with all these experts' opinion about, okay, what medication it is, what pathway does it affect, and how risky that medication or that group of medication could be. So as of right now, we know that in our animal study, when we block TNF, tumor necrosis factor, which is an inflammatory marker, when we block that or that pathway, then we kind of take away part of the immune system that is helping us to fight infections or fight anything that causes inflammation. By doing so, we have shown that when we have the animal model with no TNF, and the TNF knockout mice, they actually are much faster, get very sick with valley fever.
Oh, wow. Yeah, in veterinary medicine, we have Librela and Solensia are the TNF blockers.
Right.
So we have the same problem. We just haven't studied it.
Right. So we know if we do the same animal with the intact TNF pathway versus with blocked TNF pathway, because of the type of animal we are using, we know that animal dies faster or gets disease, valley fever, much faster than
Wow.
parental strain. So is that true for human? And we try to explore that. Not all medications behave the same in human, and not all humans are equally
There are a lot of variables.
at risk, right? So what I am right now, actually, my main focus of my study is to identify, if I draw your blood and my blood and next door neighbor blood, and look at the immune response that we can mount to valley fever spherules, the little spores, on our cells, how much immune response we can mount. And perhaps by doing so, we can say, oh, Pamela has this much immune response, and perhaps if she needs to go on TNF inhibitor because she can mount an immune response, maybe she's at lesser risk. But maybe if they draw my blood and look at my PBMCs and stimulate that, maybe if I don't develop that much response, that is interferon gamma response, then maybe I'm at more risk. So by doing so, we want to actually categorize the patients into different groups who has more immunity to the disease because they have been exposed to it longer and their cells have seen it, so they are memory cell, these people, versus somebody who comes to this area just recently, hasn't had the opportunity to get exposed to the disease. So maybe they don't have a memory to this disease. And thereby, if they go on these medications, they are at higher risk of full full presentation of the.
Wow. How are you testing the immune system? Are you testing with antibody titers or more like the T helper cells and stuff?
What we have done is, if you are familiar with uh, the tuberculosis blood test, quantified T-spot, this is a modified version of that. So what we do is we draw the blood, we separate the PBMCs, and then we stimulate the PBMC or peripheral blood mononuclear cells with the cocci, the valley fever spherules, the type of the strain that doesn't cause hazard in the lab. It's a BSL-2 level organism.
Isn't that one that you developed, the less virulent form of valley fever?
The same strain that we are using for our vaccine.
Wow.
So the strain is BSL-2, means you can handle it anywhere in the normal lab under the hood. You don't have to wear special,
the hazmat suit.
So what you do is you stimulate these cells, these peripheral blood mononuclear cells, white cells, to this spore or this endospore. And then you let them get stimulated for about 12 hours. And then you take the supernatant and you measure the interferon gamma response. And that is an indicator of memory. So if you mount enough response that, in our assay, it's considered positive, then you should be considered somebody who has background adaptive immunity to the disease. Now, what happens if, God forbid, you get exposed to the disease again? Based upon our other studies, we know that when people have immunity to the disease, they don't develop second infection. Well, that is the reason, most likely, that now the immune system can suppress the growth of the fungus. Now, what if that patient with immunity goes on one of these modifiers, biologic response modifiers? What happens to them? And that is what we are discussing now, and we try to study. Maybe some people have lesser risk of developing severe infection because of that. And that's something we are working on. Anecdotally, though, when I see some people who have lived their life here in Tucson, for example, and they are on these agents, we are all worried about them, but they don't develop very severe presentation of the disease, versus some people who may not have that long of a time frame here in the area and go on this medication because of the lack of that immunity, then they may develop the disease faster and in more severe form.
Now, is this test routinely run by the specialist? No.
No, this is what we are developing right now. I'm actually working on the paper. It hasn't been published yet, but it is somewhat time consuming, and it has a lot of steps, and it has to be standardized. But we know that that's almost same test in tuberculosis works. So it's, in other words, a tuberculosis test for valley fever.
Nice. Excellent. So is the goal to get a test going that's routinely used for people that are, or physicians that have people on autoimmune medication, to check their immunity first before they're using those drugs?
Well, that's my ultimate goal. That would take a long time for a test to be developed and they get approved. However, a shorter path to that is anybody who goes on these medications, especially certain group of these medications, not all of them are the same, because some of them are broader medication than others. But overall, if everybody tests the patients for valley fever with the normal market available test that we always do, and if anybody who was negative before now is positive, if they consider that, oh, maybe this patient is at more risk, so let me send them to Valley Fever Center, then we can monitor these patients.
So you're doing it the backdoor way. So you're checking for valley fever and then monitoring your valley fever test
Right.
to determine the risk with the biologics.
Now you remember we talked about our algorithms that we developed in a Coxie study group meeting. There are two algorithms that together with our students, I have 4 students I work with, undergrad and medical students. And all of us together, we developed this algorithm talking about if patients are currently not on biologics, what are the pathways we follow when we see them in the clinic? And if they are already on biologics, what is the algorithm tell us to do? And what I have done is sending these algorithms to different offices of providers, say rheumatologists, dermatologists, gastroenterologists. And if any of your audience like that, I'll be happy to provide that to them. We sent them about 2 months ago, and then we sent them a survey and said, hey, would you please look at the algorithm? Did you use it? Did you not use it? Do you think it is deficient? If so, where should we improve it? Because we are trying to publish that algorithm in our upcoming manuscript. And actually, by getting real life data on people who potentially will look at it and maybe use it, that give us a little better idea of how would that work and function in real life scenario in these offices.
That's really practical to do a clinical study on the physicians that are using the algorithm and what the results are, because they're documenting it with their medical records. So you would have that information potentially. That's wonderful. So you're educating the physicians that are treating the autoimmune diseases and other things on how to handle the valley fever patients.
And I'll be happy to provide that to you if you spread that. That
okay.
would be the word and raising awareness in an indirect fashion, which is, it's okay. Whatever we can do to make people think about this disease is important. And, in our IDSA guideline, if you read about biologic response modifier, it says before you start, do a screening for valley fever, which is the currently available test in the market.
Oh, it says that on the drug insert for the biological modifiers?
IDSA guideline.
The guidelines.
But
that's smart.
Only one time. I like to, and that's another thing we are working on, a couple of my colleagues and myself, to update the IDSA guideline. Because as you know, our latest IDSA guideline, written by Dr. Galgiani and other colleagues, was in 2016. And since that time, a lot of these medications have been—
a lot more drugs. Yeah.
And I think it's about time. We are working with IDSA to allow us to update that guideline. But until then, I think having this paper coming up as an expert opinion for people who are on these medications, how do we approach these patients? How do we follow them? What is the recommendation for their biologics? They do need it, but can they take it? What is the recommendation for antifungal treatment? Do they need it? If so, how long? So these are all very good open questions that we always
lots of questions with valley fever. So if there are physicians out there that want the access to the algorithm, or someone that's interested in the algorithm for valley fever with the biologics for autoimmune diseases, just contact me. I'll put my link below and I'll get that paper to you.
And then in subsequent to that, whoever you send this to, let them use it for about a month. And then we will provide you with the link for the survey to see what they think about that, because the algorithm is a work in progress. So we will be happy to take everybody's opinion and suggestion and revise it to make it better.
Nice. Now, are you doing a clinical trial with that? Like, is it an official clinical trial with the survey?
Just doing it locally right now, just the word of mouth, but hopefully we can consider doing that at one point. Yes.
Nice. Because on the vet side, we do the WOOF study where the people fill out the survey on their dog with valley fever, and then they're getting a study or research paper done with that. So we
Well,
should do that on the human side too.
I have a confession here to make. I have sent this to almost 10 doctors that I know, and I know they do see these patients. And I received 2 surveys back, so I'm still waiting. So hopefully our result will be a little bit more, on the up and coming.
All right, physicians, let's take the survey and use the algorithm so we can figure out how to better take care of people.
I understand people are busy, they're taking care of patients, time is limited per patient, and now I'm asking them after work to look at the survey. However, I really appreciate it if somebody can fill it up, because that would help us guide us how to make this better.
Absolutely. And valley fever is a huge problem, and so are the autoimmune diseases. And when you put them together, yeah, it's a double whammy.
Now,
Sure
it's
is.
said that in our study that we did and published in Open Forum Infectious Disease on the biologics, we did a retrospective review of a lot of patients in our institution, and we found that autoimmune disease by themselves don't increase the risk of valley fever. However, when they go on biologics, their risk of disseminated valley fever went up. So not only we know the result in animal, we know the result as of a retrospective study in human. So if we now can combine these together and then come with this consensus paper, that would be very helpful for people who are out there treating these patients.
Now, is this when people already have valley fever and are put on the biologics, or is this when they're put on the biologics and don't have valley fever? So their risk of dissemination goes up but the risk of getting valley fever does not?
Well, that's a wonderful question. The question is, do we, as valley fever experts, do we see patients who do not have valley fever? We don't.
Okay.
We only see people that come to our clinic because of the diagnosis of valley fever. So maybe I have to add that to my algorithm and ask people who do use these medications, how many of these patients you put on biologics, you test them for valley fever, and how many of them become positive after starting that. And that's a little bit further upstream of what algorithm I made, because I always assume they come to us, they have valley fever, thereby they are in our clinic,
So the risk is that they would develop a more severe form of valley fever, the disseminated form. That risk goes up with your biologics.
Correct.
That's bad.
Now, in our paper, we said that is 2.4-fold increase. Now, you may say, well, 2.4-fold is not 80% increase, so it's no big deal. However, for the person who is in that 2.4-fold increase,
that's a big deal.
Very severe, so it's a big deal. So although the exact number is not as much, but when you compare, it still is significant.
Wow. Didn't you do another paper on a new drug for valley fever? The Olorofim. Is that still in process and looking like a possibility?
Actually, right here, I'm writing that paper on valley fever patients on Olorofim. We're going to submit that within the next few weeks, I'm hoping. We are still in the revision step. This was a phase 2b clinical trial by the sponsor industry. The company is F2G, and this was a multi-center study, 10 sites in US for valley fever patients. Original study was a much larger study, 200 patients with a lot of fungal infections that were multi-drug resistant. We were a subgroup of those larger group, and the result is very striking for people who had truly no other alternative option. And the reason for that is they had disseminated disease. They didn't respond to anything else that is currently available in the market, or the drug-drug interaction and side effect of the medication they were on were so extreme that they couldn't tolerate it. So for those patients, I'm very pleased with the result. As I said, it will be hopefully out, published, and we all can look at it. The initial paper that was on the whole study, 202 patients, was just accepted in Lancet Infectious Disease, and hopefully will be out in the next week or two. So I would refer you to that once it is out.
Nice.
Yes. But
Nice. And that's not an azole. That's a whole different class of antifungal. And is it fungistatic or fungicidal? Does it actually kill, or is it just damaging the fungus?
Wonderful question. So it is olorofim. The mechanism is dihydroorotate dehydrogenase inhibitor. It blocks pyrimidine synthesis. And the bottom line is it blocks the DNA, RNA synthesis, protein synthesis. So it affects the fungus on different angles and kills the fungus. The animal study they did in CNS model of valley fever, it actually, the CSF was cleared from infection.
Wow.
So we all think that this is cidal agent, but you know, I don't, we don't have that data in human yet because this is still quite early. I have to tell you, some patients who didn't want to continue this for as long, because as of right now, the study is lifelong treatment. We are not yet telling patients that you can only take it for so many months and stop it. However, some patients got sick and tired of taking medication because they were better and they stopped it. And most of those people were fine for the period of time. However, because it's not in the protocol, I encourage them, no, you can't be non-adherent, please, and they go back on it. So that study remains to be seen, and that part of the
and that's just for the CNS, that's just for the valley fever in the brain.
This phase 2 clinical trial was any disseminated valley fever that was intractable to other treatments. So somebody with spinal osteomyelitis, vertebral osteobone involvement, brain involvement, soft tissue, big abscesses that were on several other agents, and we have proven that those agents either didn't work or they couldn't take it because of the side effects. These patients were eligible, of course, all adult patients. And we enrolled them. Total, we had 41 patients in all 10 sites. Here in University of Arizona, I enrolled 14 patients, and several sites such as UC Davis in Sacramento and Bakersfield Valley Fever Institute, they enrolled the most numbers after us.
That's going to be excellent if that can get out on the market. That sounds like a great option. How long does it take to get a drug like that on the market? Get FDA approved and all that?
It has gone through several steps of FDA evaluation, and we are hoping that we can fulfill their requirements. So they allow the sponsor to move it forward to the market. As you know,
wonderful.
Are always very time consuming, and lots of steps has to take place before the medication comes to the market.
Yeah. Do you ever use multiple antifungals so you could reduce the dose and reduce the side effects of the individual drug if you use multiple ones and kind of, teeter-totter them? And does that occur?
Well, if you look at our guidelines, when patients come into the hospital, say they have valley fever meningitis, that all of the azoles, they take a little bit of time for the PK value, the blood level of the medication to become appropriate. And during that time, we technically have insufficient amount of medication in the bloodstream. During that time, I usually use amphotericin, which is, as you know, very problematic from side effects standpoint. However, during that time, sometimes we have an overlap of two medication for a duration. But in our guidelines, we have to go with that. And individual providers, individual physicians, they use their experience to say, hey, maybe I should add this, maybe. But they really, based upon the guidelines, you use one azole, and then you see the effect or not, and then you switch to another azole.
Okay, so there are guidelines for treatment for people. Excellent. Wow. Now back to the immunity. Now you're doing some research on the host pathogen, and are you doing any studies on lifestyle factors like epigenetics, like how that moves into the immune system and determines whether someone's going to disseminate with the valley fever or not?
Well, one study that in our group here, one of our collaborators does is the effect of the agriculture, the antifungal agents that they are using in agriculture. And how would that affect the potential development of resistance in valley fever in the environment that then human beings get exposed to? So to answer your question, I'm kind of giving you an indirect answer, because is the fungicidal agents that they use, say, in Netherlands, was that related to development of antifungal resistance in human aspergillosis? Or the antifungals they use here to spray the crops out there, would that affect that? And that remains to be seen, but logically that should potentially affect that response of the fungus to the medication.
So valley fever is developing resistance to drugs because of the herbicides that are sprayed in agriculture?
Well,
or that's what we think, maybe.
As just we can say, oh, this herbicide is kind of causes the resistance, because fungal pathogens are a little bit different than bacterial or viral pathogens when it comes to developing the resistance. However, that remains to be seen, really.
Yeah, that's an interesting thing, because we have a lot of herbicides and pesticides out there causing all kinds of issues.
Yes.
And then also probably suppressing the immune system of individuals. Wow. Now, you're also a practicing physician, seeing patients every day, and seeing really severe patients. And you've got some protocols for the cavitary lesions in the lungs. Can you tell me about that? You know, you develop a protocol for physicians managing people with valley fever in the lungs that are the severe cases.
Absolutely. So again, going back to our guideline, the cavitary disease, and when I say cavity, is like an area of the lung, for the audience, that the tissue gets necrotic because of infection, and then the area becomes like a opening, hole in the lung tissue. It happens in tuberculosis. It can happen in valley fever. The predisposing factors are obviously underlying lung disease. In some studies, they said maybe smoking. Of course, COPD, chronic obstructive pulmonary disease, could be a predisposing factor, emphysematous changes in the lung. However, we had that question 2 years ago. I don't know if you joined us for our valley fever conference last year in San Antonio. Our symposium expert opinion was about that. So then after that, we all got together and I started writing the paper. And the manuscript finally came to a complete manuscript, was submitted to CHEST, and it just actually got accepted. It's out now. So we have expert opinion on cavitary copsy. What is it that we recommend patients or physicians do? Overall, if patients have pulmonary involvement, means lung is involved with valley fever, but they're walking and talking and they have no symptoms, our guideline, IDSA guideline says, you can monitor them. You don't have to treat patients with antifungal agent because of obviously you have a lot of side effects, right, with the antifungal. And you may not really need the treatment. Let the immune system see the fungus and take over the growth of the fungus in the body. Now, the next step is if this pulmonary lung infection become a little cavity, like a little hole in the lung, what do you do about that? Well, it's the same thing. You always look at the clinical aspects of the disease. Is patient walking and talking and doing all the activities and have no issues? Then in that case, we just monitor them. We don't have to treat that cavity with antifungal. Because as you know, and we just mentioned, antifungals that we have right now are fungistatic, means they don't kill the fungus. So then you say, okay, I start the patient on antifungal. How long do I treat? For years and years? Well, patients have to suffer through the side effects. So we say, let's hold off, let's monitor the patient, and then go from there. Now, the other group are the people who have a big cavity or larger cavity, I should say, and they have symptoms. Well, these people obviously are coughing, they may bring up blood with their cough, they're losing weight, they are short of breath. This is symptomatic. Now, this is a different category, and we do have to treat them with antifungal to at least calm down the disease, even if we can't kill the fungus. Now, beyond that, when patients have a larger cavity who could potentially rupture into the chest periphery, which is pleural space, and cause a lot of issues, well, definitely you need to treat. And in those cases, as you see in our paper, chest article, we have experts from radiology department, we have experts from thoracic surgery department, that now their role comes in and we say, okay, let me send this patient who has a large cavity, but is still stable, to the thoracic surgeon, let them know each other. And if this, God forbid, ruptures and cause more problem, now they know each other and she can, or whoever is the surgeon can then take that cavity out. And actually part of that paper, we talk about how complicated that surgery could be. Not all thoracic surgeons like to deal with this because it's an area of necrotic tissue that becomes very problematic. But thankfully, we have a good group of experts here that work with us constantly, and they are familiar with the disease and somewhat comfortable because they see a lot of it.
Wow. And now with patients that are not symptomatic, but they have underlying problems, for example, diabetes, or even some of the ones you mentioned, like emphysema, would you treat those patients, even though they were not quite symptomatic?
Well, again, it comes to the clinical presentation of patients. So if patients are stable, we can, and we are always available for our patients. Whoever is listening to this, if they have questions, they can literally call me, my landline here or my cell phone. So for these people, we prefer not to start the medication unless they are clinically symptomatic and they require it. And one reason for that is, how long do you treat? If the cavity doesn't go away, are you going to put somebody for years and years on a medication?
Right.
Or just hold off and use it when it's absolutely needed?
Well, do they typically have a positive valley fever test for the duration of having the cavity?
Generally speaking, the titer, the serology, which is enzyme immunoassay, has a lag. with clinical symptoms. So if you catch the disease, say today, as you know, the incubation period is about 4 weeks. So you might have been exposed to it 4 weeks ago. Now you start having cough and fever and chills and rash, all the presentation. And then if I draw your blood at that time, the early presentation, I may not see any positive result. Antibody production, it's a lag. Then if I say, oh, you know what, Pamela has the disease, even if I can't get the blood to show me, I repeat that test in a month. And then usually if we do sequential blood draws, because this is antibody production, ultimately we catch that. And then when it gets to a peak, slowly comes down naturally, right? That's part of the immune response. So you may catch somebody in the middle with very good immune response. You may have a negative blood test in very early on, a negative blood test at the later stage. Cavity is usually the later presentation of the disease. After several weeks, several months, then this necrotic area become a cavity. So we may not see positive serology. But, generally speaking, as we know, and, 1/3 of the community-acquired pneumonia in our region, endemic region, is because of valley fever. And about 5% of those people may develop cavity. So you can do the math and see maybe we'll see more cavities if we really look for it.
Oh, wow. Now, you did a study recently on treating patients with community-acquired pneumonia in endemic regions, kind of prophylactically or preemptively with azoles, thinking that was potentially valley fever at the start, even though they had a negative test or one they could test.
That was a study that was sponsored by NIH, and several centers, including centers in California, were part of it. Unfortunately, that study was very restrictive because of the fluconazole. Makes sense, right? Because of the side effects. And because of our patient population, that they are, generally speaking, slightly older, they are on other medication, they have heart issues. There were a lot of criteria that we had to follow before we could enroll the patient. So our enrollment was not as impressive as it was, say, in California centers.
Oh, so they couldn't have a lot of the other complicating factors.
Right.
Wow. So did that end up being a good idea? Is putting people on fluconazole as if you think they've got valley fever and have a good chance of the pneumonia being valley fever?
Well, that question comes back to how many of those people truly need fluconazole.
That's true. Yeah.
Because we don't treat everybody with fluconazole. And if you look at our guideline again, if patients come in with early presentation of the disease and they are not short of breath, they don't have low oxygen level, they are walking and talking and going to work, but they are just fatigued, the fluconazole plus or minus is not going to make too much of difference. But if somebody is admitted in the hospital and perhaps has oxygen requirement or has pleural effusion, fluid around the lung, that's a different story. That becomes somebody who is more symptomatic in the severe category. And sure enough, they need treatment.
And so are these people getting chest x-rays and do you have a rapid valley fever test in the urgent cares?
That's another great question you asked, because there was a lateral flow assay, the assay that they do for, say, a strep test or for pregnancy. That's a lateral flow assay. We were part of the study we did through another company, IMI, developing this lateral flow assay. The whole idea was exactly what you said. What if we have this really quick test? We had to spin down the blood, use the serum, put a drop of it, and then use these two eluents to in there and wait for 30 minutes and look at the line. All is good. And the sensitivity of the test, when they did the initial study on positive samples, were great. However, when we did it here in real life, the sensitivity was about 30%, but the specificity was very high. So, and then still it's a good test because if it is positive, it's in 30 minutes, you know that, right? The
So if
problem,
it's positive, it's positive, but if it's negative, it just might be too early.
correct.
And so you still need to follow up with the regular testing that takes a
So
week or
the
two.
idea is for a screening test, you want to have high sensitivity. But it's still in certain setting, it might be a very good test to do. So one of the companies that we are working with is actually trying to develop a better version of that lateral flow assay that is more sensitive. The specificity of that test was very good. So we could rule out cases that are not valley fever, but the sensitivity was the problem.
Wow. Yep, that we need more of those tests so we can get early diagnosis and early treatment with these people. And I think they're studying those tests in dogs too.
Absolutely. So in another grant proposal that we just actually got awarded with, Arizona Board of Regents, ABRC grant, we are working with Arizona State University in collaboration with them to develop this test that is hopefully very specific for valley fever. These are using specific antigens and using patient serum to identify what antigen is there and what protein is related to that antigen, and thereby maybe that would be a basis for a much better, faster, and more efficient test.
Oh, is that the study where you're banking people's serum and stuff?
Yeah.
Oh, that's cool. And
And
so you're using a different testing methodology.
correct. And that was actually presented, the basic part of the test was presented in Valley Fever in Coxie study group this year by Dr.
Yeah, sounds familiar. Awesome. Oh my goodness, so much good information.
The other
Wow.
mention is right now I'm actually continuing to develop a bio specimen bank of our patient. And I have to say, I'm so appreciative. I'm so grateful of our patients. They are so generous with their time, their blood, their urine samples. We enroll them in our studies. They donate their blood, they donate their time, they give us all the information. So we have a very large biobank now of these specimens that is being used in different, hopefully, institutions for different set of studies. So all of us can benefit from those results.
So are you enrolling more people in that?
Yeah.
So so maybe I can post a link where people can find access to helping you with that study and providing their positive valley fever samples.
Right. So this what we call biorepository or serum bank. Everybody who comes to us, if they are willing to enroll in this study, we consent them, and we obtain their information, clinical information, and then we also obtain a sample of their blood and a sample of urine. And the idea is that, for example, my interferon gamma assay is based upon that blood sample, and the serum study that I just mentioned with Arizona State University is based upon that sample. The other study that I mentioned with another company is from the urine sample. So all of these are being used to develop better tests, hopefully earlier diagnosis, more specific tests, and again, diagnose early so we prevent all the complication that comes with it, you know.
Nice. And you're in Tucson at the University of Arizona?
Yes, University of
Or-
Arizona main campus. We are at Valley Fever Center for Excellence. And just to let your audience know, I have sent you the link, Valley Fever Center for Excellence. If you go on that link, I have it here in front of me. We have a lot of little tabs in there: education, the research, what is it, the presentation in dog, what is the presentation in human. So you can actually click on those and read about it, learn about it. The other thing is in the education part, we have a tutorial for providers, healthcare providers.
Nice.
And our goal is that really for patients to be able to see their primary care physicians and discuss this with their primary care physicians or whoever is their provider, the nurse practitioner, the physician assistant, who are very familiar with the disease. So if somebody meets the criteria, they should get tested. They shouldn't wait until they get to us. And that is the basis of one of my first studies. The delay in diagnosis is the problem. And even here in our center, you think in Tucson, everybody should know about this. We had in our study in our institution, delay was more than a month for disseminated disease.
Oh, wow. Yep, that's a big problem. Yep. So getting testing known about in the medical community, and I think the rapid test, getting that used more is going to help a lot.
Absolutely. Now, one other thing is the test, the currently available test out there in Sonora Quest takes a 2-3 days. It's not like it's taken a month to come back. The issue is people think about the disease more than what tests to do. Because if they think about the disease and they suspect it, somehow they can get hold of us to help them figure out which test is the best test for them, you know.
Excellent. So the studies where you're banking the serum, is that just through the University of Arizona at the Valley Fever Center for Excellence?
Yeah.
Okay. All right. So it's patients that are going to Tucson and getting help there, and you're enrolling them in that study.
Our initial protocol is written to include patients in Phoenix as well, University of Arizona Phoenix, Banner Phoenix. However, more patients are from our center. I would say 90% of patients that I have enrolled so far, because I am here and I see these patients, so I direct them and talk to them about the study and people get enrolled. But my hope is that we can expand this to include Phoenix as well, which is a bigger center, you know, more people go there.
So we don't have the enrollment in the Phoenix Banner system yet? Or do we?
Protocol we do, but the logistics of it is a bit more complicated. People who are there, who's going to draw the blood. So for our new protocol with Arizona State University, for our new grant, we are actually developing that branch of the biospecimen repository to be more active.
Nice. All right. So we can get more information so that we can get a faster diagnosis and more treatment options.
Absolutely. Absolutely.
Wow. This is really interesting. So I will post the link below for the Valley Fever Center for Excellence site with all the information on for physicians and for the general public and for even pet owners or pet parents. And then I'll have the algorithm for any physicians or medical professionals that want that to help in their practice. I'll have that link. So just contact me and I'll send it to you.
I appreciate it. Thank you.
Wow. And thank you, Dr. Donovan, for a great talk today. I learn so much every time I talk to someone about valley fever. There's so much out there, and there's lots of new stuff coming down the pipe with all the research. There's really a lot of great information and practical information. I think that's just fabulous. You know, as a researcher, you being a researcher and a practicing physician, to be doing this research that benefits people directly. It's so wonderful.
Thank
Thank you for what you do.
appreciate your time and the opportunity, and I'm happy to do this again at any time if you think it's necessary.
Great. So maybe when more research comes out, we'll talk about when the results and the statistics come out, we'll talk about the new stuff. That would be fabulous.
I'm happy to do it.
Oh, thank you. Thank you, Dr. Donovan.
Thank
All,
you.
all right. So till the next time, thank you for listening.